Okay, so we're going to talk next about cognitive impairment. And this gets a little bit tricky with official medical definitions, with the way people view people with disabilities, and with the way that disabled people themselves would like to be viewed and perceived. So some of the language in this is in the process of changing and may continue to change. And you need to understand that people are individuals. And so we can't necessarily put people in boxes or make assumptions about their abilities. So cognitive impairment is diagnosed officially as an IQ of, 70 to 75 or below, and some functional impairment in at least 2 out of 10 adaptive skill areas. So those adaptive skill areas are communication, self-care, home living, social skills, leisure, health and safety, self-direction, functional academics, community use, and work. Or they may have deficits in one or more adaptive domains. So when we look at those adaptive skill areas, think about the ability to communicate, the ability to care for oneself, the ability to live independently in an age-appropriate way, social skills, the ability to perform or enjoy leisure activities, health and safety, the ability to keep oneself safe and healthy, the ability to self-direct. Can I decide what I need to do and make those choices safely? Academics, community use, that's can I go to the doctor? Can I use the transportation system where I live? Can I use the community? Can I go to the grocery store? And can I shop in the grocery store? Can I go and buy groceries and things like that? And then am I able to work? So those are adaptive skill areas. Traditionally, cognitive impairment is classified by severity. There are people with cognitive impairment who really don't like these classifications. But you need to have some idea of the amount of support a person needs. So when we talk about someone who is classified as mildly cognitively disabled, they may be able to work, they may be able to live independently with a lot of support, but that's not necessarily something we would expect to be possible. Moderate, they would be able to perform simple tasks, perform self-care, but not to live independently. Severe, they would be able to conform to routines, but they have to have continuous supervision. They can't be left unsupervised. And profound cognitive impairment is someone who may or may not be able to walk, but they require and to communicate verbally, but they require continuous custodial care. And again, most people who have cognitive impairment that are able to communicate their needs and preferences really prefer for this to be viewed in terms of what supports are needed for them. The etiology of cognitive impairment is often unknown. The most common causes are genetic, biochemical, and infectious. There are several goals of care. When we're caring for patients, for children with cognitive impairment, we want to educate the child and the family about that child's needs and how to meet them. When we're educating a person with impaired cognition, we need to use concrete ideas, use demonstration, break down tasks, lots of positive reinforcement, focus on what to do more than the underlying principles. Some types of cognitive impairment affect short-term memory and some do not. There are early intervention programs that help parents with those things. Another goal is to teach self-care skills. We want to promote as much independence as the child is capable of. So we want to break down tasks into smaller steps and practice those tasks. We want to promote optimal development, and that may mean intentional stimulation and practice of developmental skills. Kids who are developmentally typical will naturally seek out activities that are in the area of development that they're focused in at that time. So if they are interested in learning to walk, then they look for ways to do that. Kids who have some cognitive disability might not do that, and we may have to be more intentional about providing that stimulation for them. We also want to teach acceptable social behavior. We want to help that child develop feelings of self-worth, and we want to address and treat any physical health challenges. We want to encourage play and exercise for all children. Cognitive disabilities are fairly commonly comorbid with physical disabilities, and so we want to help accommodate for those. We want to provide toys and play based on the child's developmental age and abilities. Toys should be selected for play as well as for educational value. So helping that child find things they enjoy is important. Sports can be chosen based on the child's physical and intellectual abilities, and we need to consider safety. So for example, a child who still is putting a lot of things in their mouth at 8 or 9 years old, we need to be looking at choking hazards. We need to provide means of communication. Language delays are common. Hearing impairment may be comorbid with cognitive disability. Kids who are not able for either brain, either for a brain reason or for a motor reason, are not able to communicate with words, can learn other methods of communication, and we really should be providing those for them. There are signs, there are picture boards, and there are technological assistive devices for communication. Families need to establish discipline for the child. They need to keep limits very simple and focused on safety. They need to enforce those rules consistently. And then the rules need to be appropriate to the child's developmental abilities. We want to teach parents to focus on what they want the child to do rather than the why. Behavior modification is often recommended. Some patients with cognitive disability have objections to that. Meltdowns are not uncommon, and they are often connected to sensory overload. A meltdown is not the same as a tantrum. It often looks the same, but it's not willful behavior. It is overload and overwhelm. So managing it needs to be done a little bit differently. Another goal is to encourage socialization. So we may help kids learn what behaviors are socially acceptable. And we may help them by modeling those things, how to take turns, and role playing, how to take turns, how to talk with other kids. Learning may not transfer from one situation to another, so the child may need exposure and repetition to learn how to behave appropriately in different settings. Learning socially acceptable behavior can help protect this child against exploitation or abuse. Preschool is highly encouraged, and exposure to neurotypical children is encouraged because that helps with socialization. Providing information about sexuality. Most causes of cognitive disability do not affect sexual development. So kids who have cognitive disability will eventually develop secondary sex characteristics. They will hit puberty. They will often have sexual thoughts, feelings, and impulses. And so we need to give them good information. We need to give them information about menstrual hygiene if that's something they're going to experience. And we need to give them information about their physical development and sexuality. They need concrete rules to protect them from exploitation. There are some controversies about contraception, sterilization, and hysterectomy, and who should be giving consent to that. Should a cognitively impaired adult be able to consent for themselves, or should someone else be able to determine whether they receive a sterilization surgery, for example? We have a history in this country and in other countries of sterilization procedures and hysterectomies being performed on patients without their consent, sometimes without their knowledge, for eugenics reasons. And one of the groups that has experienced that a lot is people who were determined to be cognitively disabled. And there's a lot of controversy about that. There's also some controversy about marriage and sexual relationships and potentially having children for patients who have cognitive disability. So there's been a move in the last few decades, the last couple of decades, toward allowing and encouraging more autonomy rather than being paternalistic and controlling. So there's some, at what point is someone able to make the decision whether or not to have sex? And at what point would that actually be coercion or taking advantage? They're being taken advantage of. So there's no, it would be really easy if there's a hard and fast cutoff, but there's not. And so those are things that families need to be considering. We also need to help the family plan for future care because the child, depending on their physical health, may outlive the parents or may outlive the parents' ability to provide their physical hands-on care. So sometimes siblings are expected to do that. That can be a positive, or that sibling may be very resentful. Also, a person who has spent their entire life in the care of their parents, if their parents are no longer able to care for them or the parents die, are they then placed in a residential setting that's completely unfamiliar? So there's a lot of, they really need to be doing some advanced planning for kids who are not going to be able to be independent. Profoundly disabled children may have needs that are greater than the family's ability to meet, so they may be institutionalized from a younger age. Ideally, that's going to be in a location that the family can visit often, so they get the care they need and still have those family relationships. Some other aspects of nursing care: we may be the one who identifies a child as missing milestones, and we may also identify risk factors. So we may be involved in the identification of kids who have cognitive impairment or who are at risk for that. In the hospital, when we're caring for someone who's cognitively disabled, we need to encourage the parents to remain with the child for their safety and comfort, but responsibility for their care is not left entirely to that parent. They need a break, and the parent can't be the only person caring for them. We need to assess their developmental age. Usually indirect questions are less threatening. Assess their physical and sensory abilities and their need for equipment and devices. We should assess for behaviors that could potentially be unsafe and require intervention. We need to assess the child's ability. What are they able to do? Are they able to communicate? In what way do they communicate? Because almost everyone communicates in some way. So in what ways that child communicate their needs? Provide toys and activities. They should be roomed. If they need to share a room, it should be with a child of similar developmental age. We need to make sure we're giving developmentally appropriate explanations of what the child will experience and demonstrate those things for the child. Hospitalization can provide respite care for the parents who are responsible for that child's care all the time. Preventing cognitive disability, that may be done using genetic counseling if there's a genetic disorder in the family. We can educate to decrease those controllable risk factors like smoking and alcohol and substance abuse, things like that. Improving maternal health, teaching about avoiding exposure to chemicals, and we may be involved in communities One common cause for a long time, and it's still there, of cognitive disability has been lead poisoning. So community activism to try to get lead out of the environment can have the effect of reducing that. Okay, we're going to talk in the next couple of recordings about some specific causes of cognitive disability.